Welcome to the deep dive.
Glad to be diving in.
Today, we're looking at two areas that might seem worlds apart, really.
Yeah, definitely seem unrelated at first glance.
We've got the increasing anxiety reported in Gen Z on one side.
And then, quite technically, how things like statins, these lipid-lowering treatments, help prevent secondary ischemic strokes.
So what's the connection? Well, we think it really comes down to understanding well-being and maybe how we navigate challenges.
Exactly. And our listeners, they want to get to the core of things, get the important stuff quickly, but also thoroughly.
Right. And maybe have a few of those aha moments. So let's talk sources.
Okay, so we're pulling from a YouTube discussion featuring Abigail Shrier. She's talking about Gen Z anxiety therapy culture.
Okay, Shrier on Gen Z. What else?
Then there's a scientific review from Elsevier. It's focused specifically on lipid-lowering treatment after someone's already had an ischemic stroke.
Right, secondary prevention.
Precisely. We also looked at consumer info for Lipostat, which is a brand of pravastatin.
A specific statin.
Yep. And rounded it out with the Wikipedia entry on statins generally, just for broader context.
Got it. So the mission for this deep dive?
I think it's really to pull out the key insights from these, well, quite diverse sources.
Looking at maybe the potential pitfalls of focusing too much on emotional struggles without also building up that resilience.
And at the same time, seeing the undeniable impact that proactive medical steps can have on long-term physical health.
Okay, sounds like a plan. Let's start with Abigail Shrier's points about Gen Z. She mentions something about their sense of efficacy.
Yeah, it's quite striking. She points out that Gen Z seems to report, more than millennials did, a lower sense of their own effectiveness, like feeling they have less control over outcomes.
An external locus of control, is that the term?
That's the one. And linked to that, she suggests, is maybe less desire to be in charge, feeling more afraid, or not quite up to tackling big challenges.
That's interesting. Does she give any examples?
She does. She shares an anecdote from a friend, a cell biologist, who works with top pre-med interns.
So really break kids.
Absolutely. But this friend noticed they were, well, almost afraid to run experiments independently, always feeling like they weren't quite ready, and also frequently bringing up their mental health status.
So it raises that question about balance, doesn't it? Acknowledging feelings versus, getting stuck in.
Exactly. And Shrier really digs into that. Where's the line between validating emotions, which is important, and doing it, as she puts it, irresponsibly, meaning without also giving kids coping tools?
And showing them the upside, the reward of pushing through something difficult.
Right. Her argument is sort of, if kids are never told to just suck it up for even minor things, do they ever really discover their own resilience, their ability to handle stuff?
It's like that muscle doesn't get built. She mentioned a study too, didn't she? In Australia.
Yeah, the Wise Teens program. Apparently teaching specific coping techniques actually led to the teens feeling sadder and more anxious.
Wait, teaching coping skills made them more anxious. That seems counterintuitive.
It does. But the researchers thought it might be because the focus made them dwell on the negative stuff more. Rumination, essentially.
Rumination. Constantly replaying negative thoughts.
Exactly. And this, Schreier suggests, points to a bit of a split, maybe, within the psychology field itself.
How so?
Well, she observes that academic researchers might be more likely to acknowledge potential risks or downsides to certain therapy approaches.
Okay.
Whereas some therapists actually practicing, she suggests, might minimize or even deny those risks.
And she used that Jiffy Lube analogy.
Yeah, pretty pointed comparison suggesting, that the business model of some practices might incentivize keeping clients coming back, perhaps longer than strictly needed.
Wow, that's quite a claim. She even mentioned a child psychologist using waivers.
Yes, requiring patients or their parents to sign something acknowledging that therapy itself isn't risk-free. It can have unintended consequences.
It really underscores that it's not always a simple fix.
And Schreier brings up concerns about whether therapists always get to the root problem, or if there might be incentives, perhaps unconscious ones, to prolong treatment.
Like the example related to gender identity issues she mentioned, suggesting other underlying factors might sometimes get overlooked.
Right, and this ties into her idea that maybe, for some therapists, treating less severely ill patients for longer durations could be, well, a more sustainable or appealing practice structure.
Which links back to that idea of rumination, doesn't it? If you're constantly talking and thinking about problems.
They can feel like they're getting bigger. She explicitly connects rumination to being a known symptom of depression. It's not necessarily productive processing all the time.
So what's the alternative she suggests?
Getting active. doing things, accomplishing tasks, even small ones like exercise or running errands, shifting the focus outwards,
No.
essentially.
Moving from introspection to action.
Yeah, which she argues can often be more beneficial for mental well-being than just sitting with the problems constantly.
She also brought up context, like how much safety and security we have.
Right. The idea that maybe constant, intense rumination over smaller issues is a kind of luxury afforded by a relatively safe life compared to someone facing immediate severe hardship who just doesn't have that bandwidth.
It changes your perspective on what constitutes a major problem.
Which connects to her point that the worst thing that's ever happened to you is the worst thing that's ever happened to you. It's entirely relative to your own experience and tolerance level.
But even with all these concerns, she stresses something important about human history.
Yes, absolutely. The importance of telling kids the amazing story of human resilience, that despite immense pain, loss, hardship throughout history, people have overwhelmingly found ways to endure and rebuild.
Which feels quite different from maybe the current trend she identifies.
Of quickly labeling difficult experiences, even common ones, as trauma, requiring extensive therapeutic work.
And she suggests maybe being disconnected from older generations, from extended family, and their stories of overcoming adversity plays a role.
Yeah, like losing that historical perspective on resilience that family stories often provide.
And misusing terms like PTSD.
Exactly. Drawing a sharp distinction between, say, having a bad memory of being bullied and a genuine PTSD flashback, which is a very specific clinical phenomenon, cautioning against watering down these terms.
It's also important to remember that anxiety itself isn't always bad, right?
Absolutely crucial point she makes. Normal anxiety is adaptive. It can boost performance, help memory formation, motivate us to change things that need changing.
The key is differentiating that from an anxiety disorder, which is debilitating.
Precisely. Which leads to her final concern in this area, the potential downside of trying to medicate away all negative feelings.
Because those feelings might actually be telling us something important.
Right. They might be the very motivation we need to make a necessary change in our job, our relationships, whatever it is. Dampen the feeling. Maybe you dampen the motivation for positive change.
Okay, wow. That's a really dense set of ideas to chew on. Let's completely switch gears now. Let's talk strokes and lipids.
Okay. Moving to our second topic. The Elsevier review really sets the stage. Stroke is huge. Second leading cause of death worldwide, major cause of acquired disability.
And if you've had one ischemic stroke, the type caused by a blockage, your risk of another one or a heart attack goes way up.
Significantly higher, yes. Interestingly, the review notes that initial studies maybe saw a weaker link between cholesterol and stroke compared to, say, high blood pressure.
So blood pressure was seen as the main culprit initially.
It was definitely primary focus, but more recent evidence, and a lot of it, has really solidified the connection. High LDL cholesterol, the bad kind, clearly increases risk for cerebrovascular disease.
And the flip side, lowering it helps.
Definitely. Lipid-lowering treatments show a clear benefit in reducing that risk. There was a big meta-analysis showing a significant drop in stroke risk for every Amalzell decrease in LDL.
That's a direct dose-response relationship. How much of a difference can treatment make overall?
The review suggests potentially preventing up to 80% of recurrent events, second strokes, heart attacks with the right therapy.
80%, that's massive.
It's a huge potential impact, yeah. Now, there was one study, SPAR-CL, that initially hinted at a possible increased risk of a different stroke type, hemorrhagic or bleeding stroke, with high-dose atorvastatin.
Okay, so a potential trade-off.
It raised a question, but later sub-analyses of SPAR-CL and other large studies haven't consistently shown this increased risk, especially for most patients. It shows how science refines things over time.
Right, it's rarely black and white, and it's not just statins alone being used now.
Correct. Combination therapy is increasingly important. Adding drugs like ezetimibe or the newer PCSK9 inhibitors to a statin shows further benefits.
Any key trials for those?
The improved dial provided good evidence for adding ezetimibe after a cardiovascular event. And studies on PCSK9 inhibitors also show they significantly cut ischemic stroke risk further.
So we have effective tools, but is everyone who needs them getting them or getting the right dose?
That's a major challenge highlighted in the review. Undertreatment is common.
Really? Even for high-risk people?
Yes. The EuroAspire V registry looked at patients across Europe who'd already had a stroke, or TIA. A huge chunk still had LDL levels well above the recommended targets, even though most were on statins.
So maybe not on the right statin or not a high enough dose or maybe needing that combination therapy.
Exactly. It points to a gap in applying what we know works. Aggressive lipid lowering is key for these high-risk individuals. High cholesterol is definitely a target we can hit.
Okay, let's zoom in on one specific statin mentioned. Lipostat, which is pravastatin. What does the info tell us?
Well, it confirms it's pravastatin sodium, and its job is to inhibit that enzyme, HMG-CoA reductase.
The key enzyme for making cholesterol in the body.
Right. By slowing that down, it lowers cholesterol production. The info also notes pravastatin is hydrophilic, meaning it's more water-soluble than some other statins, and basic stuff like storing it correctly.
And the Wikipedia overview gave a wider picture of statins in general.
Yeah, it touched on situations where specific statins might be preferred. Like, for kidney transplant patients on cyclosporin, pravastatin or fluvastatin might be chosen to reduce interaction risks.
What about other groups?
For HIV-positive individuals on certain protease inhibitors, atorvastatin, pravastatin, or fluvastatin might be options. And if someone's taking gemfibrozil, another lipid drug, atorvastatin might be used, as combining gemfibrozil with other statins carries a higher risk of muscle problem.
And interactions, like with warfarin.
Yes, it notes that starting any statin might require adjusting warfarin dosage, the blood thinner, standard monitoring practice.
Okay. What about the side effects we always hear about with statins?
Wikipedia covers the common ones. Muscle aches or weakness are the most talked about, also a slightly increased risk of developing type 2 diabetes, and potentially elevated liver enzymes.
The muscle pain, is that as common as people think?
Well, the entry mentions there's debate. Some research suggests true statin-induced muscle issues might be less common than reported, and the nocebo effect could play a role.
The nocebo effect, like the opposite of placebo.
Exactly. If you expect a negative side effect, you might be more likely to experience or notice it, even if it's not directly caused by the drug.
Interesting. But there are rare, serious muscle problems.
Yes, very rare, but serious ones like rhabdomyolysis, severe muscle breakdown, and an autoimmune muscle condition have been linked to statins. They require immediate medical attention if suspected.
And the diabetes risk?
It's noted as a real, though generally small, increased risk. But the general medical consensus, as mentioned, is that for people needing statins for cardiovascular protection, the benefits usually far outweigh this potential risk.
What about cognitive effects, memory issues?
The FDA has noted reports of reversible cognitive impairment, things like memory loss, confusion with statin use.
Reversible, though.
Yes, typically not serious and tends to resolve if the statin is stopped. Still something to be aware of and discuss with a doctor if it happens.
Can we briefly touch on how they work again, beyond just blocking that enzyme?
Sure. Blocking HMG-CoA reductase is the main thing. That reduces cholesterol synthesis in the liver. The liver then compensates by putting out more LDL receptors on its surface.
Which act like little docking stations.
Exactly, to pull more LDL cholesterol out of the bloodstream. So you get less production and more removal. Wikipedia also mentions those pleiotropic effects benefits beyond lipid lowering, like improving blood vessel function or reducing inflammation, though the main benefit comes from LDL reduction.
And the history. Someone specific discovered them.
Akira Endo, a Japanese biochemist, did the pioneering work in the 70s. Fascinating story of scientific discovery, though some early compounds had issues.
And it also mentions the danger of bad information.
Yeah, sadly. It notes how misleading media claims about side effects have led people to stop taking their statins, putting them at higher risk of heart attacks and strokes. A real public health concern.
Underlines the importance of reliable sources. Okay, so we've covered a lot on Gen Z anxiety and resilience and a lot on strokes and statins. How do we tie these threads together? They still feel quite different.
Well, think about the underlying theme. Both topics, in really different ways, are about navigating challenges and promoting well-being.
Okay, how so?
With the Shrier discussion, we're looking at the potential pitfalls of focusing so intensely on internal emotional states, maybe without adequately building the skills or mindset to cope with external difficulties.
Right, the focus on feelings versus resilience.
And then with the stroke prevention, we see a very different approach. Proactively managing known physiological risk factors to prevent a devastating future event. It's about taking concrete action based on evidence.
So one is more internal focus, potentially passive, the other external action, very proactive.
Kind of. And consider this. If someone has that strong external locus of control, Shrier talked about feeling like they don't have much influence.
Yeah.
Might that also make them less likely to stick with something like long-term statin therapy? If you don't really believe your actions make a difference, why bother taking a pill every day for years.
Ah, that's a fascinating potential link. Your mindset about your own agency could impact your physical health behaviors.
It could. It suggests that maybe for overall well-being, both mental and physical, we need to acknowledge challenges, internal feelings, or external risks. But crucially, also focus on proactive strategies and believe in the possibility of positive outcomes. Taking action matters.
And in both cases, getting the right information is key.
Absolutely critical. Avoiding the extremes, not over-pathologizing normal feelings on one hand, and not falling for exaggerated fears about proven medical treatments on the other. Misinformation is harmful in both domains.
Okay, so wrapping this deep dive up, what are the main takeaways for our listeners?
I'd say two main things stand out. First, the importance of finding that balance. Acknowledging emotions, yes, but also actively fostering resilience, coping skills, and maybe a focus on action and accomplishment.
Okay, balance in the mental approach.
Second, recognizing the profound impact of evidence-based medical interventions. Lipid-lowering therapy is a powerful tool that demonstrably prevents strokes and saves lives when used appropriately for those at risk.
So embracing both internal strength building and external medical tools.
Pretty much. And for you listening, being truly well-informed means looking at these complexities, understanding that health involves both mind and body, and considering different viewpoints critically.
Which leads us to maybe a final thought to leave everyone with.
Yeah, something to ponder. We know from history that humans have an incredible capacity for resilience. We see it time and again.
Right.
So the question becomes, how can we best equip ourselves and the next generation to navigate life's inevitable bumps and bruises, drawing on that innate resilience, while also fully embracing the genuine life-saving benefits of modern medicine?
Finding that sweet spot between building inner fortitude and wisely using the tools science has given us.
Exactly. How do we balance fostering emotional well-being and resilience with proactively managing our physical health through proven interventions? That's the balance to strive for.